Good afternoon. Our presentation today is about pineal gland tumors. Let's start by reviewing the pineal gland anatomy. It is also known as the epiphysis cerebri. The average size ranges between 5 to 10 millimeters with an average weight of 100 grams. The pineal glands obtains its arterial supply from the posterior choroidal arteries and drains indirectly through the internal cerebral veins, eventually into the vein of Galen. It is primarily concerned with the production of melatonin, which controls the rhythmic or circadian rhythm of sleep. However, it also has a role in the reproductive function during puberty, controlling hunger, thirst, and sex drive. It is located in the center of the brain, related to the posterior surface of the posterior wall of the third ventricle. It has a superior lamina known as the habenular commissure and an inferior lamina known as the posterior commissure. It projects posteriorly into the supravermian cistern. It is related to the undersurface of the internal cerebral veins as they join together to form the vein of Galen, and it is closely related to the underlying superior aspect of the tectum and the superior colliculi. Usually, it calcifies in adulthood. It is rarely found to be calcified below the age of 10 and almost never calcifies before the age of 5. It lacks blood-brain barrier and hence its enhancement after contrast administration. It is often seen as an incidental finding on CT and MRI in approximately 5% of cases, although on autopsy it is found up to 40% of cases. It has a female predominance of 3:1, and although it is usually simple, cystic, unilocular, and maybe containing some simple septae within. However, if it contains some solid components, it gets confusing to differentiate it from pineal gland tumors and may warrant follow-up MRIs, particularly if the size is bigger than 1 centimeter or has atypical features. When it gets larger, it compresses the adjacent structures and results into different types of symptomatology, depending on the compromised part of the brain. So as it grows and expands, it may compress the superior aspect of the tectum and the superior colliculus, resulting in difficulty in upward gazing, the so-known perinodes phenomenon. May also obstruct the aqueductive sylvius, resulting in hydrocephalus, may compress the posterior aspect of the internal cerebral veins or the formation or the junction with the vein of Galen, resulting in deep internal cerebral vein thrombosis, which may result subsequently into bilateral thalamic infarctions. The pineal gland itself is asymptomatic and does not usually warrant any further investigation. Imaging, it has slightly higher density than the CSF because of its proteinaceous contents. Frequently demonstrates peripheral pattern of linear calcification, may contain chunky calcification within its inferior aspect. On MRI, it usually shows a cyst with a fluid content that is almost matching CSF. After contrast administration may demonstrate a peripheral enhancement of its wall, usually thin, may be complete or interrupted. Hemorrhage may occur within these cysts, particularly if they are big, and that's known as pineal gland apoplexy. It is an uncommon incidence and may have symptoms of acute sudden onset of severe headache, could be associated with some meningismus or even consciousness disturbance. Rarely results into any endocrinological disorders. should be further evaluated to make sure that no underlying obvious pathologies could be detected. This is a large pineal gland cyst with blood debris within its posterior aspect. You can see here the blood fluid level and the multiple septation within the cyst itself, as it is also demonstrated on this T1 weighted images with higher proteinaceous content within the cyst itself and the blood debris in the posterior aspect of the cyst, in a dependent part of the cyst. Moving on to pineal gland tumors, we can classify them into tumors that are arising from the pineal gland, which are primarily the germ cells and the pineal cells, and tumors that are within the vicinity of the pineal gland, whether they are arising from the neighboring structures, such as the gliomas, meningiomas, and lymphoma, and metastatic lesions from elsewhere that may also reside in the region of the pineal gland. However, our main concern in this presentation is about the lesions that are arising from the pineal gland itself, which are mainly germ cell tumors, as they constitute 70% of the tumors. These are mainly germinomas and teratomas, less likely embryonal carcinoma, choriocarcinoma, and yolk sac carcinoma. Pineal cells, whether pineocytoma or pineoblastoma, constitute 30% of the pineal gland tumors, less likely papillary tumors and parenchymal tumors of intermediate differentiation. Now, radiologically, these tumors all look alike, with the exception of teratoma that has certain features, primarily the presence of cystic changes and fatty content. However, the rest of all pineal gland tumors, mainly the germ cell tumors and the pineal cell tumors, they all look alike. So how do we diagnose them? We primarily diagnose them based on the age, sex, and the tumor markers in the blood and CSF, as well as histologically after obtaining a histopathological confirmation. Symptom-wise, as I said, according to the mass effect on the adjacent structure, they may result into hydrocephalus, Peyronie's phenomenon, bilateral thalamic infarctions, hydrocephalus because of obstruction of the aqueductive cell base, etc. Endocrinological disturbance is rather uncommon. So the imaging part is primarily for documentation and road mapping rather than actually giving you the histopathological type of the lesion. When we talk about the germ cell tumors, we're primarily concerned with germinomas and teratomas. The germinomas and teratomas look alike, with the exception of teratomas demonstrating cystic changes and fat content. However, both are usually iso to hyperdense on CT with areas of calcification. They are hypointense on MRI, iso to hyperintense on T2 weighted images, and demonstrate strong enhancement after contrast administration. You see the same features in teratomas, except they are slightly larger. They have multicystic components, and they have, and this is calcification as well again here, and the fatty content that is seen. So the presence of fat and multicystic changes are main features of germinoma, otherwise main features of teratoma. Otherwise, germinoma, teratoma, embryonal carcinoma, choriocarcinoma, and yolk sac tumors all look alike. Finally, if we move to pineal cell tumors, we also identify that radiologically they look similar to germinomas. They are iso to hypo-intense on T2, they enhance strongly, maybe they are larger, they contain calcification, they are iso-dense on CT, they cause the same symptomatology in terms of obstructive hydrocephalus, etc. So you cannot differentiate pineal tumors, whether they are pineocytomas and pineoblastomas or germinomas from each other. You can differentiate teratoma if you're lucky enough to identify the fatty content. So it's primarily on the age, the tumor factors, and in terms of pineoblastoma and pineocytoma, the pineoblastomas are rather aggressive, occur at a younger age, and appear to be larger and irregular in outline, in comparison to pineocytoma, where they occur at a later stage of life. They are benign and they are small and well defined. So, if we summarize, then we go back that the pineal gland tumors are primarily the germ cells and the pineal cells. They all look alike radiologically, with the exception of teratomas that have fatty content and maybe microcystic components. Otherwise, they all appear the same. Anatomically, it's the same location. Symptomatology, it depends on the pressure effect on the adjacent structures. We should, because of the aggressiveness of some of these tumors, do contrast-enhanced MRI and include the entire neuroaxis for that, because CSF seeding is common. CSF tumor markers and serum tumor markers are important, as well as obtaining histopathological confirmation is mandatory, since some of these lesions, such as the germinomas in the germ cell, are highly radiosensitive, while others may need surgical and chemotherapeutic measures. Thank you very much.